We're okay. We should be recording now. All right. So again, I am Dura with True Heart Hospice and Palliative Care, and feel free to stop me as you need if you have any questions. It's really more about what is palliative care and what is hospice that we're going to be talking about, not necessarily the differences. So just some numbers and some facts that I found interesting that I wanted to share with y'all before we get into it, and why hospice and palliative care is really an important part of helping people stay healthy, stay at home, and learn how to live their lives on their terms. So 90 million people are living with serious illness in the United States. 20% of all Medicare recipients have 5 or more serious medical conditions. 18% of Medicare recipients are readmitted within 30 days of hospital discharge. That's awful if you think about that. And you don't want to get out of the hospital and then get back in right immediately thereafter. 50% of Medicare patients go to an emergency department 1 month before death. 33% of those people are admitted to an ICU. 20% will have surgery in the last month of life, and 80% of 90 million people say they want to avoid hospitalization. Most people do want to avoid being hospitalized, and if you can imagine in the last month of your life that you're going into a surgery, that's not a quality time with your family. So what happens, or for yourself, so what happens often is people look for alternative means for taking care of themselves and their loved ones without having to continue to go back and forth to the hospital. So of course, there's problems that we incur every day in our own healthcare and in the healthcare of the people that we love. And that's difficulty managing care with 3 or more doctors. I know myself, whenever I go to the doctor, I've stopped going because they don't communicate with each other, and then they never communicate back with you. And it seems like nobody knows what they're doing half the time. So for me, it becomes very challenging, and I can only imagine when you're trying to take care of a loved one or yourself and you've got multiple health issues going on. Consumers also need referrals to get services, and with lack of urgency from a provider, it's difficult to get that sometimes or get it in a timely manner. There's issues with polypharmacy leading to medication that counteracts with each other and continuing medications that are no longer helpful or useful. There's challenges with mobility, which makes travel challenging. Sometimes it can be impossible. There's financial constraints, lots of medicine being bought, hospital bills, all of those things. Loss of involvement with your community and often with your family, and increasing need for medical care are problems that we typically see with people that are looking for alternative means for care. So palliative care and hospice care defined. Palliative care is specialized medical care for people with complex medical and social needs. And it's care that's provided through a case management model by a multidisciplinary team at the patient's location. Location can be either your home, it can be a skilled nursing that you live in, wherever you call home. And it's care provided regardless of life expectancy. So palliative care you can do in conjunction with home health. You can do in conjunction with seeing your doctors and doing aggressive treatment. It's helping you during that time that you're still looking for aggressive treatment, and yet being there to transition you at the time that you choose you no longer want to do curative or aggressive treatment. That's when hospice care comes in. So hospice care, it's not transitional care like palliative. It is a special kind of care where we focus on the quality of life for people and their caregivers who are experiencing advanced life-limiting illness. So hospice care will provide compassionate care for people in the last phases of an incurable disease so that they can live fully and comfortably. It provides a medical director who will oversee the care plan for each patient. Although the patient doesn't see the medical director, the care team will work with the medical director. The care team includes a certified nurse, an RN, a certified nurse's aide, CNAs, a social worker, pastoral care teams. They also include volunteers, although right now with COVID, we're not seeing sending out volunteers just because we're trying to make sure we minimize the amount of people that are actually coming into contact with the people that we take care of. And we treat patients wherever they call home. So if you have a loved one that's living in a skilled nursing facility or a memory care community, assisted living, we'll help them in that community by sending in our CNAs to help with showers, to help with you can do, it's not considered physical therapy, but movement therapy to help you stay limber, help you learn how to stand up, and help your caregiver move you and transition you. So there's a lot of things we can do within the facility setting. And then we also help the social service and spiritual care side works with the family members at home. So a lot of times when you're taking care of someone, especially now with COVID and your loved ones in a facility setting or community setting, I like the word community better than facility, just because it it feels nicer. And so if your loved one's in the facility setting and you're not being able to see them as much as you want, especially right now with COVID times, you need that extra support at home. And hospice doesn't just take care of the person in that needs the care, the person with a terminal diagnosis. It also helps the family. So we can go into your home and we can help you with any of those social needs, that social service needs that you need, or spiritual care needs that you need. So it really does benefit both the patient and the family member. So what does palliative care do? Palliative care, it dedicates a social worker. There's different models. The True Heart model is a social service model with a dedicated social worker that will help manage care and resources for the family members of the patient. We work within the patient's healthcare plan. Although with True Heart Hospice, it is a free service that we provide for families, with the understanding that there's a likelihood that they're probably going to transition at some point to hospice, although that's not required. We become an agent for action to get needed referrals for equipment that families may need, medication and treatments, doctors referred to them if they need a doctor. We help with things like food insecurity and so much more. Right now, we're hearing a lot about when I go out and talk to the doctor's offices, that their elderly patients are finding it challenging. And I think, Ina, you put the question in the box about, is it difficult to get the vaccination right now? A lot of times, because you have to have an appointment, even online, just to go to the free places to get it done. Elderly people are finding it really challenging because they don't know how to work the computers and how to get in there and find, where do I go for this and how do I sign up for it and all of that. Well, that's where palliative care can work hand in hand with those physicians. We can send our social worker out. Our social worker can take their computer and help somebody sign up, and then make sure they know where to go to get their COVID shots. So well, that's not a little thing. It's things like that, but it's also things like identifying if say you need a ramp and yours is dilapidated or you don't have one. It's working with our social worker will put you in touch with different groups that can come out and do that for free and create ramps for you. It's helping make sure your bills are getting paid. It's dealing with food insecurity and setting up Meals on Wheels. There's so much that goes into a palliative care program that is from the social side of things. It does not provide you a medical team, but we do work with your medical team. We identify programs, as I said, that the patient will qualify for. And do they have any benefits from previous employment or military services? And can we help you apply for that and find additional financial resources if you need that? We identify community programs, as I said, Meals on Wheels, and assist the patients in efforts to remain independent and self-directed. Again, on palliative care, you do not have to have a terminal diagnosis, but you do have to have an illness and some condition that also includes a barrier to care. Then hospice, what hospice does, the primary goal of hospice care is to ensure that every moment counts in a person's life. In the last 6 months of life for a terminally ill patient, we want to empower them to live the rest of their life on their terms. Good hospice services will go much further than that, though, and they'll include the following goals, which we send out a certified nurse's aide to do hands-on help with everything from helping to tidy up your home, from assistance with activities of daily living, volunteer visits when we're not in COVID times, Of course, you have an RN that comes out and does your blood pressure checks, medication management, and ensures that the medical side of things from the nurse's perspective is taken care of. And you have the oversight of the medical director who's going to be looking at medications that you're taking. Are there those drug interactions that we talked about earlier that we should take you off something or titrate your medications down? We look at all of those things, and oftentimes you find out that when somebody comes on hospice, they tend to get better because they didn't have that level of care before they got on hospice. And now they've got somebody coming in multiple times during the week and helping with everything from hygiene. So you're not necessarily getting as prone to picking up different types of bugs and viruses, to medication management. If you think about how many times people are on so many medications that they've been taking for life, and you ask them, why are you taking this? Now, I don't know. I was prescribed that in 1989. And I never stopped taking it. My doctor never told me to stop taking it. Well, it's not necessarily helping you. And the older you get, you have to break down all those medications, and it can actually make you sicker. So we see people sometimes get better on hospice, to even to the degree that we call them a hospice graduate. They actually come off service because they no longer need hospice. But for those that do continue to need it, we're able to continue to support them and support their loved ones. And by supporting the loved one, that's supporting the caregivers during and after the hospice process. So we will follow family members for 18 months after the loss of their loved one. We get them through that first year of major events, from anniversaries to Christmas to Thanksgiving, to all of those things that you now have to experience without that loved one that has passed away. And then we continue to follow you for another 8 months after that first year, just to make sure everything's okay. We're checking in on you. Is there anything we can do for you? You become part of a hospice family when you invite us into your home and into your life, and we think of you as that. We help with bereavement support, and we make sure that you're grieving appropriately. And there's a range of grief support programs, from traditional support groups like Caregiving Cafe, where we would refer you to pet therapy. So there's a range of types of services and therapies that we can assist with in helping make sure that families are grieving appropriately. So palliative care, the main focus of palliative care is symptom management, it's infection control, it's communication with your physicians. So not our doctor, not our nurses. We're going to be communicating with your doctor and learning what your goals are and their goals are for you. It's care coordination. So goal clarification and advanced planning. So as a family, what are your goals? Are you wanting to do 2 or more treatments? And then if those aren't getting better, you want to go ahead and transition to hospice? Or what do you want? And then we make it happen. I love the way Charlotte, our owner, she always says palliative care. She puts the magic wand in the social worker's hand, and she tells the social worker to hand it over to the family member that she's talking to. And she says, if you could wave this magic wand and make your life look better today, what would you need to do that? And what would that look like? And then we start from there. And I think that's really the perfect visualization of what palliative care does. And I always tell the people that I work with, ask for anything. If you don't ask, the answer is always no. If you do ask, there's a likelihood that, believe it or not, if we can't help you with it, we can find somebody who can. And if we can't, with no harm, no foul, you just know that it can't be done with us anyways. And we do our best to make sure that your needs are met. So the focus of hospice is pain management through comfort care. You're no longer seeking aggressive measures. You're no longer wanting to do treatment any longer. You've been in and out of the hospital multiple times. You continue to have to take antibiotics or whatever that situation is. And it has become more challenging for you than the idea of just being comfortable and being able to spend time with your loved ones or by yourself and manage your care on your terms where you call home. It provides you spiritual care. And any part of the hospice care team, from the spiritual care coordinator to the social worker to so the chaplain, the social worker, the medical director, the CNA, any of those team members, you can choose who you want to see and who you don't want to see. You don't have to see them. So if we're working with family members that they're not particularly, they don't practice a certain um, religious belief, or they don't want to see a chaplain. All they have to do is let us know that's not what we want. It is non-denominational. We're not pushing religion down on anybody. What we do try to do is, from that spiritual side, there's a lot of times family issues that need to be addressed, and sometimes when you see somebody not passing away, it's because there's something going on. There's a family dynamic, or a personal fear of what might happen, and our spiritual care coordinator and our social worker can work together on helping the family overcome those issues that they may have, where everybody's in a better place, and that person passes in a way that is comfortable for them. And then there's care coordination with the social worker and the family, patient and family education. So hospice is not there's a misconception that people think hospice is 24-hour care, that we move in or we move you to a hospice house. That's not what happens. We go to your home, wherever you call home, and we educate the family on how to take care of their loved one when they're home taking care of them. Or if they're in the facility setting, we help the staff in making sure that they're getting showers, making sure that they have socialization, making sure that they're doing range of motion movements and getting up and out of the bed if they can, or being turned so they're not having any type of skin breakdown or anything like that. So it's educating them. And then of course, as the person who is on service, their needs increase, the number of visits will increase, all the way through to being with the family. If we aren't there at the time of passing to help them through that, we are there shortly after to help with the grieving, to help with making sure that your loved one is taken to the funeral home of your choice, and to help you through all of those things. So hospice is end of life focus and management. Comfort care, palliative care is still wanting to focus on getting better and moving forward. So the palliative care population, it's a community-based palliative care service that serves individuals and families that are coping with advanced illness. So you do have to have a barrier to care, and you do have to have an advanced illness, although it doesn't have to be terminal. That's the difference between palliative and hospice. So, but you no longer qualify for your home health services. That might be the time to look into, they're saying that you're not getting better. You're not able to do any kind of the treatment. That might be the time to reach out to hospice and see if we can step in, and then we can start to provide that care at home. Hospice will cover everything from your medical equipment, bed, undergarments, medication, all of those things. So it's a great transition from home health to hospice when you can no longer qualify for home health. If you're having difficulty in predicting your prognosis, you're going, some days you're better, some days you're worse. If you qualify for hospice, there are periods where you have to recertify. If you've truly gotten better, you're not recertified, but that gives us the time to take a look and see at an overall picture of health. And that might be the time when you're having that difficulty predicting what your prognosis is, to reach out and have a hospice evaluation. Patients requiring symptom management, patients and caregiver requiring help identifying available community resources and support, and patients discharging from a hospital or rehab facility, or reoccurring visits to the doctor's office. All of those are people that may want to consider reaching out to a palliative care program so that we can assist in how to move forward. Again, when you no longer meet those, you may want to meet with somebody like me and do your consents. You can always ask for a hospice evaluation without having an order from your physician. Now, to begin treatment, we have to have orders, but you can choose a hospice of your choice, and you can also ask for an evaluation and then move forward with getting the recommendation or referral from your physician. So hospice care serves individuals and families that are coping with advanced illness. So it is a terminal diagnosis that if you looked at the overall group of people that had that diagnosis, their average lifespan would be 6 months or less. It doesn't mean hospice is not going to bring death on, and it doesn't slow it down. What it does is it makes you comfortable and in control of what's happening in your medical choices. And if you no longer qualify for home health services, you're no longer seeking curative treatment, you require pain management. Hospice is really the only group that can manage those morphines and those pain medications on those higher dosing levels. So there may be a point in time where you really want to reach out to a hospice, if for nothing else, for that pain management. And then patients and caregivers desiring help to remain comfortable wherever they call home. And the most important thing is you must want hospice. So many people qualify for hospice, but they just don't want that. They're not there for whatever reason. The family's not comfortable with it. They're not comfortable with it. So you can meet all those qualifications, but if you don't want hospice, then you don't get hospice. So the two main things: must have a terminal illness, must want hospice. So palliative care initiatives, they effectively improve the quality of care in the home setting, as well as hospice. Hospice does the same thing. You reduce reoccurring ER visits and hospital admissions when you go on a palliative care, because we're proactively monitoring what's happening, and we're able to make sure that we're kind of meeting your needs prior to having to go to those hospitals. Hospice, of course, you're not going to be going to the hospital anymore. So you won't be having those readmissions. Now, we don't stop you from going to the hospital. If you choose to, that is your call. We just need to know so that we can discharge you when you do go to the hospital. You can come on and off hospice as many times as you need to. Palliative care delivers and coordinates community-based services, and they expand palliative care access to other community health systems. What makes palliative care effective? So it's time to devote to intensive family meetings and patient family counseling. It's expertise in managing complex physical and emotional symptoms such as pain, shortness of breath, nausea, depression, caregiver burnout. Palliative care helps provide treatment for secondary infections before they become an emergency situation, and they allow you to treat it for independence and treat it independently of having to go to the hospital necessarily, but doesn't prevent it. Palliative care is really designed to remove barriers to care and reduce the gaps in services. And the candidates that we see, again, for palliative care are, that is, I believe, my hospice one here. Sorry about that. No, it is. Okay. Ignore that first part where it says in the last 6 months. That was part of a different thing for hospice. So palliative care candidates, if you've had 2 or more trips to the ER, if you've been admitted to the hospital, if you've had 1 or more falls, if you've had difficulty getting to the bathroom in time, if you've had difficulty leaving the house, you need oxygen some or all of the time, or you've experienced weight loss. If you've had, I'm sorry, this is actually candidates for hospice. So forgive me. I was making some edits prior to coming on, and I didn't add that in. So these are the candidates for hospice. Again, last 6 months of life. If you've had 1 or more infections requiring antibiotics, if you need help with complicated household tasks, if you've had change in sleeping patterns, had wounds that aren't healing, you're no longer receiving curative care, then those are all things that you may want to look out and consider. Or if you had received care in the past for COPD, heart conditions, or diabetes, those are all diagnoses for hospice care. Palliative care consultations. What is important to you right now is the first thing that we want to know. That's that wand that I was talking about. How can we make your life better right now? During that consultation, we want to know, what do you understand about your health conditions? And what have other care providers told you about your prognosis or your diagnosis? And what would you like to know? We answer those questions that you may not have had time to talk to the doctor about, and we help you understand what your options are. And then we help you meet your healthcare goals. We also can assist you through palliative care and also through hospice care with getting a living will in place, a DNR, or deciding who your power of attorney is if you don't have those in place. The social worker can come out and meet with you wherever you choose to meet and help you get those in place. And that's both on the palliative side and on hospice side. Coordinated care results for both palliative and hospice. We ensure that patients get the right care at the right time. We decrease the fragmentation and frustration when multiple physicians are involved. We see patient satisfaction across the board because they're no longer having to go doctor visit to doctor visit, hospital in and out, that revolving door to the hospital. And we see lower rates of infections that do result in those hospital and ER visits because we're managing your care at home, especially right now with COVID times. So palliative care interventions, physician oversight. Again, the social worker is going to work with your physician, whereas hospice oversight is the medical director for hospice. You can choose on hospice to have your own doctor follow. You would have to let us know that though, and then your doctor would have to agree to continue to follow you. They have the right to say, we want the medical director of the hospice to follow, but you have the right to request that we ask your physician to follow you in hospice. So palliative care, we work with your physician. Hospice, you work with our physician. Disease and symptom management is an intervention with palliative care. With hospice, it's going to be controlling the pain or comfort care measures there at home. Clarification of goals, both in palliative care and hospice. We want to know what you want, which team members you want to meet with, and then we want to set about making sure that we meet your plans as a family as well as the patient. Medication management, that's on the hospice side of things. That does not fall under palliative care. Patient caregiver education is both palliative care and hospice care. Caregiver support goes under both palliative care and hospice care. Coordination of community resources and on-call services. Both of those are will fall underneath palliative care and hospice care. And the outcome, the final outcome that we find out when you choose to use palliative care or hospice care is that you have improved controlled physical symptoms, you have reduced patient and family anxiety, timely implementation of care plans that are realistic and consistent with the patient goals, and support of patient and families, increased patient family satisfaction, fewer readmissions to the hospital, and a smooth transition between care providers and a smooth transition from palliative care to hospice when that time comes and if that time comes. So at that, I complete and will answer any questions that you have. Again, as I said, you can always request an evaluation, whether you're in a facility or whether you're at home. The only thing that would require is reaching out to me. That's my phone number, and letting me know. And in the email you have that Lynn sent out, you also have my email address, and we can do consents, send out an evaluation, and a nurse for an evaluation. And after that, then we would move forward with orders should that be what you decide. I always say getting the information, having an evaluation gives you all of the information. It doesn't mean you have to choose any service. It just lets you know what you qualify for. And knowledge is power in everything that you do. So that's it for my presentation. I am going to stop recording. And then if y'all have, well, actually I'll keep recording for questions if anybody has any questions, and then I'll stop recording after that. So while we're recording, does anybody have any questions or anything that they would like me to address that I didn't address or confused you with? You can just ask it, Ina. You don't have to type it.
Oh no, I'm just putting a note here to check for your email address. That's it's a good thing.
I'll give it right now.
I really
Also
appreciate this because this is very helpful. Having just done this with my father, and I can see the difference between my mother and my father. He was very thankful for the palliative care, and then they moved him into hospice. And it was our first experience doing that, and it was very good. And it did help lower our stress levels somewhat. And now that I'm looking at my mother and her various conditions, I now feel better prepared for when I need to do this for her, because I was not prepared when I needed to do this for my father. So I appreciate the clarification between the two, and that one service can help move you from one to the other. That's very nice. Mhm.
Thank you. Yeah, and that's a great personal testimony. Thank you for sharing that. My email, if anybody does want to write it down, is DURA at truehearthospice.com. So again, it's my first name, Dura, at truehearthospice.com.
Awesome.
And if there's no more questions, I am going to go ahead and stop recording.
I have a question.
Yes.
Okay, I work with mostly low-income people, and I was wondering how expensive it is for an initial consultation. A lot of them do have insurance. Some of them have Medicare. I was just wondering how, you know.
It is free to have an evaluation done, and both services are free to the patient and the family member. So through True Heart Hospice, because it's a social service for the palliative care, we provide that as a free service. We don't bill Medicare, we don't bill Medicaid, we don't bill insurance or the family. So that is a free service that we provide. Hospice is billed to Medicare, and Medicaid, and some insurances will have a hospice benefit as well. So your Medicare Part A, you can't have home health and hospice at the same time, because they both bill the same, that Medicare. And choosing home health is choosing to continue to have treatment, whereas choosing hospice is choosing comfort. But it's free to have an evaluation, and it is a free service.
Well, thank you.
Absolutely. Anyone else?
I had a quick question. If nobody else has anything to ask right now. And I know, well, I learned only from being with my mother, when you have your first experience of somebody actually dying in front of you, or spending time with somebody who is actually dying. Actually, a couple things. One, can you talk briefly about dying and actively dying, which I had never heard of before. I thought you're either dying or you're not dying, but those are technical terms, medical terms. So the difference between those two. And also, you mentioned medications. And can you also briefly talk about why in the dying process, not through a diagnosis of diabetes or cancer or anything like that, why would you need medications? Just I'm looking for a very brief description of, or where we can get more details about what I'm going to call the dying process, because there are some things that may come up as the body is approaching end of life, which many of us are not familiar with. And like you talked about medication management, I mean, how does that translate to a hospice situation?
Anything else?
Yeah, something like that. Yes.
Is there anything else you want me to add to that? I wrote down the things you wanted me to address.
Yeah, no, they have tons more, but let's keep it. We only have till noon. I think that might be another opportunity for a more in-depth look at the end of life process. What's actually happening to the body, which I had no idea, like I said, until my mother it was in my care. So, but that might explain why some of these things are needed, as opposed to, okay, you're offering these wonderful services, but I don't need that,
Mhm.
is what somebody might think if that person is unfamiliar with the actual process of the body dying.
Mhm. Sure.
So anyway, okay, I'm just looking at it, I guess, from my experience of not having been through this. I wasn't there with my dad when he died in ICU. I was here with my mother, and I really had no idea what was going on and what to expect.
Sure. Okay. So I'm going to answer that in kind of in order of how things would happen from medication management to end of life and what to expect on that. So you asked, why would somebody need medication during a diagnosis and up through end of life? So especially when somebody first comes on hospice, we take a look at all of the medications that they're on, and most likely we're going to start removing those medications. And families will often, or even facilities will often say, well, why are you taking them off that? They need that. Well, we look at, do they really need it right now? And at the state of where their health is at and they're nearing end of life, does it really help them to take that triglyceride pill or those, um, whatever the medication may be, right? That they may be taking it because they've taken it their whole life. And we start to reduce those medications, but we may add other medications. So there may be a need to add pain medication. And it might need to increase, and likely it will need to increase as you get closer to end of life. Why is that? Because the dying process is it's natural for all of us. Our bodies will start to reject food. It'll start to reject water. And families and even facilities that haven't been educated on what end of life looks like, they think it's cruel to stop feeding the person at end of life or to stop giving them water at end of life. The reality of that is your body is naturally rejecting those things. And when you try to force somebody to have food and water, they can aspirate. And that is extremely painful. So you don't want to force somebody to eat and drink. And what they're going through at end of life, it's different than you and I experiencing hunger and thirst. You're no longer experiencing those sensations. Your body is naturally shutting down. And now you do want to do things like keep your loved one comfortable by you can get little sponges and put water, on their lips, on their mouth. You can put Vaseline around it to keep it from drying out. There are things that you can do to minimize what would be a natural side effect from dehydration, right? And make that more comfortable. And that's part of what the hospice team does. The hospice team will teach the family how to take care of their loved one and accept what's happening, right? So we're not feeding them for this reason. We're letting them get closer to end of life. As they get closer to end of life, you'll also start to notice that along with rejecting food and water, in those last final hours, there are 24 hours or so. It's called the death rattle, and it's a kind of a gurgling sound that you might think of if, say, you had phlegm and you were, kind of that sound. And then what we see sometimes is the family will call us and say, okay, I'm hearing that rattle that you talked about, and they're sleeping more. They're not, they're not communicating any longer. They're not eating. They're not drinking. We believe that it's imminent, and the hospice team will show up, and lo and behold, the person sits up and they're like talking, and you think they're going to get up and run around the room, and people are like, oh my gosh, my loved one's better. People can sometimes rally at end of life, and it doesn't necessarily mean they've gotten better. it doesn't mean that they're going to have much longer. What it means is their body is jolted into a sense of energy and rallying that appears to be getting better. And then within 24 hours or so, they are back on that decline and usually pass shortly thereafter. Not everybody rallies, but many people do. And sometimes when you see people that are hanging on, for lack of a better explanation, hanging on to life, oftentimes what will happen is they're waiting for their loved ones to leave the room. They don't want to die in front of somebody, or they need somebody to have closure. And so our social services and our pastoral care are really great at talking to the families and saying, you know, we really anticipated he was going to pass away, you know, 24, 48 hours ago, or the families will say, why is he still here? And that's where we take the time to sit down and ask about those family dynamics a little bit deeper. So we talked about, you didn't have a great relationship growing up. Let's talk a little bit more about that. And then we figure out what the situation is. And if it's bringing somebody in for closure, if they're willing to do that, oftentimes you see then after that happens, somebody passes right away. And sometimes it's, they're waiting for people to leave the room. They don't want to die in front of those people. And when everybody leaves the room and we're out talking to the families, they pass away at that time. So it's different for everybody, is basically what I'm saying. End of life is different for everybody. The support that you get during that time is what's really important to help families grieve appropriately and understand what's happening. Did that answer your questions?
Yes, thank you. Yes. Can you
I'm
just
looking over to see what else you asked.
actively dying versus dying?
And
So-
I've noticed also in what you said, it's very true. And sometimes they just need your permission to go.
Yes, I was just going to say that. Oh, Ina, sending you a big hug.
Yeah.
Thanks.
Yeah, that I was going to say that, you know, from what I have been told, sometimes a person who's close to end of life needs to hear that the people that stay are going to be okay, even though that person is going away, you know, because they might be worried. And it might be a little scary for them too, you know. So I know my sister told my mom, you know, it's okay. It's okay to go. And we have a very strong, you know, Christian faith. So, you know, my sister told my mom, it is okay. And, you know, Jesus is waiting for you and God is waiting for you and it's okay. And we're going to be okay. You know, my husband also had to say that to his father. You know, don't worry, we're going to be okay.
My dad, sorry, my dad,
there.
my dad passed my dad was in the hospital and like Dura said, you know, the thing with having the surgery, he had surgery and passed away 8 days later. And so we truly, he had the hospice team had come in and talked to him, and actually while they were there,